again. Together we make up the SoCal Consulting Group, and today we're here to present to you Children's Care Reimagined. A quick overview of what we'll cover today. We're going to go into a short story of a little boy named Tomas. We'll give you our current environment. We'll give you our proposal. Then we'll talk about our strategic plan, what operational adjustments go along with that, and then we'll wrap up with our financial model. So now I'll turn it over to Poonam.
Good morning. This is Tomas. Tomas is a sweet and lovable little boy in Riverside County, California. Just like every other 5-year-old, he loves to play outside. His favorite thing to do in the whole world is to play basketball with his papa on Saturdays mornings. Unfortunately, he also suffers from asthma. Imagine that today's Halloween, and the only thing that he wants to do is go trick-or-treating with his friends dressed as Spider-Man. But unfortunately, he's at home sick in bed instead. When he was sick, his mother was unable to identify his flu-like symptoms. So when she goes in the room to check on him, she finds him unresponsive. Unfortunately, his family does not have access to a primary care physician or even a medical home. So when it comes down to it, the only option that they're left with is to go to the emergency department for all of their medical needs. So in an utter state of panic, his mother goes, picks him up in her arms, takes him straight to the emergency department, and hopes and prays that he's just going to be okay. Unfortunately, Tomas falls as prey to the statistic that 60% of children in Riverside County do not get their flu vaccination every year. And he also is a victim of a very fragmented healthcare system within Riverside County, California.
What's truly unfortunate is that this is not the only story that exists in Riverside County. There's hundreds, if not thousands of more. And as a consulting group, we've been tasked to correct this issue in Riverside County. Let me first talk to you about the market profile and the current environment they're in. Riverside County is one of the fastest growing areas in the United States. It's comprised of around 2.2 million residents, 27% of which are children under the age of 18 years old. We are very conveniently located in the southern part of California, next to San Diego, as well as Orange County. Some of the issues that we face are as above. We have prevention, cases like Tomas not getting the flu vaccinations, changing alternate strategies. Obesity, due to lack of physical activity, as well as increased amount of leisure time in the area. Physician integration. We need to get our physicians involved with partnering with our community so that they can tell them the things that they need to do outside of the hospital setting. Finally, poor nutrition. More kids eating fast food every day, and we try and get them to participate in their own health care as well as educate them on what they need to know about. This is what I mean. Compared to California, we are negative in all areas that I just mentioned, and we want to fix that. Let me first start off by talking about Greater Los Angeles Valley Children's Center. They are a not-for-profit, 176-bed children's center. They have around 276 physicians which they partner with. In addition, they have around 2,000 employees. Now, ambulatory care center, their volumes have been declining since 2011. This has led to around $6 million loss since 2010. We believe that's due to high supply expenses, as well as unprecedented growth in employment workforce, and finally because of increased length of stays and readmission rates. We think we have a solution for this, and our proposal is to merge with Riverside County Family Centers. Let me tell you a little bit more about Riverside Family Care Center. Over the last few years and last years, they have been known as a safety net for Riverside County and their patients. They take patients regardless of their income and ability to pay. They are comprised of 10 federally qualified health centers, as well as specialized ambulatory care centers, as well as primary care centers. As we go forward, we not only want to merge physical entities, but we also want to merge our cultures. That is one future, one culture. Our vision is to equip our children and the greater community with the resources necessary to participate in their own sustainable health care. The key word here is sustainable. We not only want Tomas to have a good health care this year, next year, and years down the road, we want him to have lifetime good health, participating in his health care, and have his children participate in their health care. Finally, our mission is committed to the health and well-being of Riverside County through clinical expertise, outreach, advocacy, while providing quality health care regardless of income or ability to pay. And we believe that this is going to proactively change our care model from sick care to preventative and wellness care. We want to get ahead of the curve. We believe we can improve our health outcomes. We can get our patients to participate in disease self-management. And we also want to increase our access to care. Let me show you what I mean. Here in the top left, you'll see where our children's center is located. By partnering or merging with Riverside Family Center, we'll have 10 convenient locations around the area, but we don't want to stop there. We want to make it convenient for the patient and the parents of our children. I'm sure we all know that children don't get sick in the most convenient times, so we want to do something about that. We want to have after-hours and weekend coverage for 3 of the centers located in our area, making it convenient for our patients and children, so it's not always the best idea to go to the ED. And once we merge, we're going to have a change of governance structure. At the top of this, we want to have the board of directors, below which we have the CEO and president who have delegated responsibilities directly from the board. Below him, we will continue to have the COO, CFO, and the CNO. In addition, we want to have the Community Health Center Board, and they will delegate to their members the 4 area supervisors located in the area, coordinating the family care centers. They've done a great job so far. We want to keep that up. Now, the 2 major stakeholders in this entire process are the patients and the physicians. Without them, none of this is going to be possible. We want to have the patients participate in their own health care, and we want to have our physicians let them know what they need to do to participate in their health care outside the hospital setting. We also want to hold them accountable. We want to make them accountable for some of the supplies that they purchase, the vendors that they go through. And here's our strategic plan, coupled with some strategies and our tactics. Operationally, we want to divert the volume from our ED to the ambulatory setting. We want to do this by creating the PAC team, the Pediatric Ambulatory Care Transition Team. They're comprised of social workers and nurses, letting our patients know what they go to the ED for, what they go to the ambulatory care center for. We're hoping that this is going to reduce some expenses in the ED volumes. We're also hoping to reduce overall supply expenses by entering into GPOs and centralizing our supply purchasing. In addition, we want to integrate services across the care continuum through EMR consolidation. This needs to happen before 2015, and again, we want to get ahead of the curve and really jump out there. We want to stake our regional footprint in the community. We want to be known as the end-all, be-all for children's health care in Riverside County. And we think we could do this by getting together with some of the community members and partnering with them. Let me tell you a little bit more what I'm talking about. We want to have a community outreach program. We're going to tally Greater Life for Greater Los Angeles. Our partners are going to be schools, employers. We want to reach out to these individuals where they are the most receptive. We want to get our physicians involved, have them out in the area as well. Our PAC team is going to be very, very crucial in this entire process. We want to have health fairs and educational events, and we're going to fund this through fundraisers. We think we can capitalize on our children's center and be out there on a bi-monthly basis, raising as much as $30,000 every other month. Finally, we want to get in touch with our children. They're on social medias now. We have Twitter, we have Instagram. We want to have links on these websites, link them back to our website, letting them know what foods they need to eat, what activities they need to be productive in. Finally, we want to take advantage of the Medi-Cal expansion in the area, and those who are not involved in this, we want to enroll them in exchange programs. And this is why our PAC team is going to be useful. That's our strategic plan. I'm going to hand it over to Poonam, who's going to tell you how we're going to implement this.
Thank you. Now, there's 4 areas within the strategic plan that we have identified, and we have set very specific goals with each area. For operational, we'd like to see a 15% increase in ambulatory visits, 10% decrease in preventable emergency department visits. In finance, we'd like to see an overall decrease in supply or expenses, but we're going to specifically focus on supply and salary. By year 3, we'd like to see an achievement of a 1.9 net operating margin. Regardless of where you are within this new system, we still want to maintain the highest level of quality possible for all patients that we see. And there's 2 metrics for which we've set. First is we'd like to be ranked in the top 90th percentile in the country in patient satisfaction as measured by Press Ganey. Second, we'd like to see a reduction in harm index events by 2% annually, and this will also help us proactively prepare for value-based purchasing in the future. And finally, as a way to reach out to the children in Riverside County, we would like to see 5% of these children enrolled in wellness programs and increase the flu vaccination rate from 40%, where it is currently, to 80% as measured by the Healthy People 2020 benchmark. Now, in the day-to-day operational setting, we'd like to see some adjustments made, beginning with after hours and weekend coverage, truly expanding our primary care services beyond the 9 to 5 basic setting. This will be located in 3 family care centers throughout the county. On Monday through Friday, they'll be open 5 to 10 p.m., and on the weekends, 8 to 1 p.m. Next, we need to begin looking at how we operate with truly a new lens. We need to find ways of eliminating variation, find ways to consolidate our efforts, and truly operate efficiently. And a few ways we can begin those efforts is through physician alignment, monitoring our supply usage, as well as reducing our staffing levels and really begin auditing our pharmaceutical orders on a daily basis to eliminate waste altogether. Our biggest adjustment in the operational setting is creating this Pediatric Ambulatory Care Transition Team, also known as PACT. This will consist of social workers, registered nurses, financial counselors, as well as community partners. It's an outpatient care management program, and it's truly patient-centered. This is where the team coordinates their care from the time that they're in the acute care setting, and they go with them throughout the entire continuum from post-acute care to ambulatory to primary care to the home setting. This PACT team will be with you every step of the way. And some pilots that have been done around the country have shown a reduction in length of stay, readmission rates, patient days, seen an improvement in inpatient throughput, as well as achieved what we're seeking to find, an increase in ambulatory utilization. As a result, now the care model will look like this. A patient will come to the emergency department, such as Tomas, will be identified as not having a medical home. Then the physician will refer that child to the PACT team. The PACT team will then intervene, enroll them in a medical home, give them the financial counseling needed, truly educate them in daily health management, and begin to build a relationship through also home visits, taking the care team outside of just the 4 walls of the medical setting and really extending their reach. And as a result, the family will have access to a truly integrated continuum of services, receive the education that they need to manage their health on a home level. And now Emmanuel will tell you about the financial implications of our proposal.
Thank you. So first, let's look at our actual system and the services that are provided under that umbrella. In the first column, you see things that are offered in our family care centers. Essentially, you're seeing primary care, but it goes beyond that. It's also services that many of the low-income individuals in this community desperately are in need of, such as the WIC program, testing for HIV and other STDs. In the specialty care clinics in the center, we see our specialty care clinics that are focusing on providing the care that these patients may need in the ambulatory care setting. And then the final column are the services offered in our children's hospital. The inpatient setting, providing services that, again, these people need. What we want to do is create a shift in traffic. On the top, it represents a shift from the ED into the primary care setting, identifying little boys like Tomas through our PACT team and getting them the care that they actually need. On the bottom represents a shift of referrals into our system, whether it be through ambulatory care or referrals for inpatient surgeries or stays. We're able to keep all that traffic in-house and really do what we think is going to provide a continuum of care, all within one system. Again, this is another representation of a model. Focus in the center is our family and children's centers. Around it, each represents a vital role in the success of the system. Without its success, the system can be vulnerable. But if we continue to push and support each other, we really feel that we can create, if you will, a circle of life. Our financial model, our outpatient budgets, we really think that volume is going to increase at a pretty consistent rate. But what we think we are able to do is record a 1.9 operating margin by year 3. This comes from 2 key factors. The first is a reduction in supply expense, which Alex touched on in the beginning. Through group purchasing, we can reduce our supply expense by roughly 10%. That makes up about 1% of our operating expense. So roughly, we're able to save about $2 million there. The second is from a reduction in salary expenses. Per volume, we anticipate that salary expenses will reduce by 10% over the three-year period. As far as the ED, you notice that volumes are going down. That traffic is again shifting into the primary care. Roughly over about 10% is reduced over those 3 years. In the first year, about by 2%, 2% in the second year, and 6% in the third. Another key factor here to note is, again, we're reducing salary expenses per volume and reducing supply expense. Another component is a reduction of uncompensated care. In your appendix, in Appendix A, you'll see a full breakdown of the uncompensated care. What we realize is that because of the insurance exchanges, as well as Medi-Cal expansion, many of these self-pays are going to transition into insurance-holding individuals. We feel that reduction will improve our reimbursements and allow us to really not tackle the problem completely. The ED will still lose money, but we're able to do it in a way that allows us to continue providing the care that these people need, but without doing it ineffectively and inefficiently. And finally, in our outpatient, we recognize that volumes are going to go up. We feel that this is an area that we can really optimize our performance in. It's already successful. In the year 2012, it recorded an 8.1% operating margin. We have space to grow, and we're going to continue to do that. Through referrals and pushing traffic into our system through our family care centers, we feel that we can generate the volumes that we anticipate. 3% increase in year 1, 5% increase in year 2, and 7% in year 3. Our key savings here are operationally our supply expense. We're reducing supply expense or operating margins by about $2 million for the Children's Center. That cost savings should transition into the family care centers, roughly 10% savings in supplies there. In the ED department, there's a $1 million reduction in operating expense. Again, it allows us to operate that department in a reasonable expense. So now I'll turn it back over to Poonam to wrap up our story with Tomas.
Thankfully, Tomas was able to receive the life-saving care that he needed that evening in the emergency department. Now let's fast forward 3 years. At this point, all of our goals have been met. Our operational adjustments are fully functional. Tomas is now 8 years old, and he is no longer a victim of the fragmented healthcare system, because that night he was enrolled and referred to the PAC team. They enrolled him into a medical home, gave him the education he needed to maintain his asthma at a home level. And the beauty of this program is that since that Halloween night 3 years ago, he hasn't had to come back to the emergency department once for another asthmatic attack. And his family, his mother, his father, and his baby sister were also able to be enrolled in the medical home, changing the course of their health care going forward and truly improving their quality of life. We'd like to see more children like Tomas adopt this delivery care model, really shifting the focus from sick care to wellness and prevention, because it ends up resulting in improved long-term, better health outcomes. Thank you for your time. This is the conclusion of our presentation.
My question is, I just want to be clear, so your strategy is a full merger with Riverside Family Center, is that correct?
Yes, that's correct.
Okay. Do you know what percentage of their patient payer base is non-Medicaid or non-Medi-Cal? Do you know what percent?
We weren't able to actually find all that data. We were able to find the county's budget as far as the expenses. A vast majority of the patient is Medi-Cal based. Exact numbers we do not have for you.
Being a federally qualified health center, that's what you can expect. Yes.
Well, right. So I'm making that assumption, but I didn't want
Yes.
to
No.
assume that they don't have a commercial population. So with your strategy leaning toward a full merger with an entity that basically serves Medicaid
Yes.
patients, how do we ensure that we keep a stable base with our commercial patients and so we have a good balance of payer sources and, of course, the stereotypical healthcare status, of the different populations?
Of course, thank you. Well, that was part of our community outreach. We want to have physician alignment not only with our physicians and not only physicians at Riverside Family Center, but physicians in the area. That way we can have some referrals from them, getting them together in social settings so they trust each other, so we could get more of these commercial payers. We do and will accept all payers, but we do want some of these commercial payers. It's giving more of a carrot game if we do get them together and we get these commercial payers.
So it seemed like your presentation focused mainly on that vulnerable population.
Yes.
You did think about the
Yes,
other
we did
population.
think about the other
You just wanted
population.
to, okay.
Have-
So one last question. So with your revenue projections, what percentage of revenue comes from the inpatient side? I know you talked a lot about the outpatient side, but I didn't hear a lot about where we were going with the inpatient side.
We actually weren't given a budget estimating the inpatient side, so we made assumptions based on what we did have. We were given the ED, outpatient, and then operational as a whole.
So what assumption did you make as far as that revenue breakdown?
Roughly assume that length of stay would reduce. We also assume that uncertainty with the change in the payer mix. I'm sorry, in the reimbursement model.
Mm-hmm.
It's really hard to say what would happen, so we tried to keep that as consistent as possible and made the assumption that would stay fairly the same from year 2012.
Okay.
And these assumptions were made really for the next 3 years. With preventative care and wellness care, and that's shifting. It's going to be longer down the road when we see the changes and the implications of what we're doing here. It's just we were just only asked to do it for the next 3 years.
Thank you.
No problem.
How did you choose the health indicators that you decided to focus on?
The health indicators on the executive dashboard.
The quality indicators that you.
We chose them based on looking at different organizations around the country. What are they really focusing on? What's really made an impact on decreasing preventable occurrences within their organizations? We definitely don't want any communicable diseases. We want to maintain the highest level of avoiding preventable occurrences. And by choosing those 3 indicators as indicated within the appendix, we think we can accomplish that. And that's a good starting point because those are also measured by the CMS, which is directly linked to value-based purchasing.
Well, you mentioned that you wanted to decrease the harm index by
Right.
2% annually.
Mhm.
Where are we now that we would need to decrease it 2% annually?
Well, I believe this decrease is just compared to Healthy People 2020. We're getting on these sites and talking about Mission 2012 and all these benchmarks, and we want to reduce compared to them, where they see themselves in 8 years. We want to compare ourselves to that as well.
One question particularly. The PAC team. Is that funded, and I assume, because I was looking through your financials, between the main hospital, the outpatient clinic, and the emergency room? So how is that funded? And are those people, like you mentioned, are part of one of the 3 organizations? Are you pulling that team together? Is it a people that you're going to have new people you're going to employ? How are you going to fund that?
It's really going to be a reallocation because we do have an excess of staff currently within the system, so it'll be more of a reallocation, a special training for these folks to really become peer coaches for our patients. As far as the funding goes, it will be more of a reallocation. It will be a hybrid model between the family care centers and the hospital, and so they'll be working along all of the entities
Do you anticipate a RIF?
of RIF.
Reduction in force?
We anticipate there could be some, there could be a rift. Essentially, but we feel that may be a component, and that's going to help reduce the force. Currently, we're above the industry standard. We have more people serving less people in comparable hospitals. We feel that this is the only way that we can really provide the care that we're seeking to do for these people. And if there is some backlash, some resistance, we feel that that'll be accounted for in our reduction in force.
And to follow up on that, like, we did not want to lay off our employees. That's not something we wanted to do. So we were doing the attrition. We're trying to freeze everything right now. And a lot of this can be funded through some of the community outreach and the fundraisers. Like I said, we're trying to raise up to $30,000 every other month.
I'm so
this-
glad you said that.
Yes.
Please tell me how you raised $30,000 from a health fair.
Well, not just from a health fair, just from a children's-centered perspective. Getting out to the community, getting out to these employers, these partners with schools, trying to get them more involved with the situation and the process, letting them know what degree and the situation that we're in currently.
So just to piggyback on that, just an example of that is partnering with the local college, University of California at Riverside, having a dance marathon. Many of the universities throughout the country are doing this, and it's raising a lot of money for these children's centers. So just activities like that that can generate revenue to really go to serve a good cause. People are really willing to help children when they see that there's a need for it.
So why are the FQHCs, what's in it for them? And why are they going to agree to this merger?
Well, I'm glad you asked that. One of the issues going forward with the Affordable Care Act is that they need to be implementing the EMR setting. This is before 2015. Now, some of the issues that primary care settings do have is the fact that they don't have the clinical expertise, the time, the organization to implement the system. We want to help them out with this clinical expertise. They are getting funds through HIT money, so that's not an issue. In addition to that, we do want to get some more referrals, volume-based, and transition to a value-based system. And also with getting these more commercial payers, as we assume we will, through these physician social settings, that'll give them more of a care in the game as well.
And if I could just add to that, currently, looking at their financials, the county loses about $9 million on these centers every year. That money is transferred from other funds throughout the county. We feel that by us going through a cost savings approach, we really feel that they can benefit from that system as well. It really saves some money on their bottom line.
Mm-hmm. And the organizational structure where you've got the board for the health centers, who comprises that board?
On that board, there's a chairman of the board as well as other members as well. We plan on moving the chairman of that board to the board of directors, therefore give them a little more say in the game as well.
So those are, but who else is on that team, on that board?
On this community health center board?
Yeah.
It's similar to that. There's their board of directors for the FHQC.
Okay, all right.
So it's members from the community, respected members of the community. Like I said, they're very enriched from the community.
And now, and they're going to be reporting to whom in your organizational structure?
They shall be reporting to our CEO, president, in which, because we did not want to have multiple members in which our board of directors will be delegating to. We know that this can cause confusion, this can cause a rift, as you've been saying, and we did not want to get this involved in that. So.
Don't go too far.
In your financial model for your operational expenses, did you account for inflation?
Yes, we grew volumes by about 3.5% annually. Essentially, it's just a rough estimate. It may be a little more, but we felt that we needed to add something in there, so we did.
I mean economic inflation, not volume.
Okay, I'm sorry. No, we didn't. We focused on the shift in payers as far as in reimbursement.
Did you complete a risk assessment of this merger?
I'm sorry.
Did you complete a risk assessment of this merger and the potential negative impact that it could have on our health center?
We looked at
Our
several
medical
variables. Mainly, what is that going to do for the community? Our goal was to focus on population health again. We felt that at the end of the day, the pros outweigh the cons. Really felt that it was limited on the risks.